So this is a big question. Should we be using diarrhea prophylaxis? I think that if you use diarrhea prophylaxis, you are going to have less diarrhea. And I have used that for quite some time with my patients, both with pertuzumab as well as with neratinib. However, we have also learned that if you take that approach, some patients will actually have constipation. So another approach that I sometimes use for my patients, it sort of depends on whether they're naturally prone to constipation or diarrhea, is to not take it prophylactically, but take it readily the first loose bowel movement you have, and then take a double dose, and then take it every 6 hours. We do tell patients not to take more than 12 2-milligram tablets a day, but that way they can stay on top of it. Sometimes we use drugs like Lomotil, and there's a randomized, not a randomized study, but a non-randomized study looking at diarrhea control called the control study that is testing a variety of other drugs such as bile sequestering agents like cholesterol, and also non-absorbable steroids have been tried. And it looks like the bile sequestering agents might be the most effective, at least with the preliminary data that's been presented so far, but we need a little more information and follow-up to solidify those recommendations.
When starting neratinib, diarrhea prophylaxis should strongly be considered. Based on the control trial, we can say that loperamide with either budesonide or cholesterol or both should be used, because you can see that the results were significantly improved for the rates of diarrhea compared to the Extenet trial, in which no prophylaxis was mandated.